All right, we're going to go ahead and get started tonight. I'm going to be your trainer this evening. My name is Sarah Vanover, and we're going to be talking about, oh, just a reminder to everybody, make sure to stay on mute, because there are just over 60 of us on here. It could get really loud if we all have home background noise going on. But we're going to be talking about an introduction to epilepsy and seizure first aid tonight. And this training is sponsored by the Face It Coalition, a movement to end child abuse, and it is funded by COSARES for Kids, who also is very dedicated to reducing child abuse and making people aware about child abuse prevention in the state of Kentucky. So again, COSARES for Kids, there we go. Like I said, I'm going to be your trainer this evening. My name is Sarah, and I work with Kentucky Youth Advocates. My job at KYA, I work in early childhood education policy, child care policy, and in special education policy. So tonight kind of overlaps both of my main two loves. I also work with our Face It movement, and we have a special breakout group of Face It that specifically works on reducing child abuse for children with disabilities who are typically 3 to 4 times more likely to experience abuse than a typically developing child. Few housekeeping things. You need to have your cameras on so that we know you are watching since we aren't live. We want to make sure that people are participating, and that's part of the requirement with doing virtual trainings to get ECE TRIS credit. You have to stay on the training the entire time. And then at the end of the training, in order to receive credit, there will be a SurveyMonkey survey that you complete that just gives us, you get to evaluate the training, and then you also make sure that we get the essential information for ECE TRIS. I have to enter all the ECE TRIS data into their system within 10 days of this training, but they have a warning up on their website right now that they've been running a little bit behind. So it could be 2 to 3 weeks before they get it in, but that will still be in plenty of time before the June 30th cutoff. So no worries there. But typically, like a day or two after the training is over, I have people emailing me saying it's not in TRIS yet. I'm like, well, it takes a little bit longer to show up in most cases. So don't worry if it's not there just immediately. One thing before we get into the content tonight, I want to share with you is the Kentuckiana Epilepsy Foundation is a great resource in the state of Kentucky for supports for individuals with epilepsy, children who are having seizures. They have a lot of different aspects, and we put a QR code on there for you to scan if you'd like to go to their website, check out their resources. They've got art therapy, they've got support groups for families and for children. There's more training on seizures and how to support kiddos with epilepsy that they do both for teachers and for community members. And so they are a great resource. They are one of our Face It partners. And I just want to make everybody know that they are available. They do events across the state. I live in Lexington, and usually the end of May, beginning of June, they have their annual 5K, and they do them in 5 different places in the state. I know Owensboro has one, Louisville has one, Paducah, and maybe Hazard, but they have chapters that are active throughout the state, but this is their main website, and they are great resources for that. So we're going to start talking about our content tonight. Before we really get into it, I have a question for people to put an answer in the chat for me. What is the strangest thing you have ever heard somebody say about a seizure? There are all kinds of weird wives' tales and different perspectives that people have about what the reason behind epilepsy is, why somebody would have a seizure, what you need to do to stop a seizure. So I'm interested from you all. What are some of the strange things that you all have heard that you are pretty sure are completely inaccurate? Um, put a spoon in their mouth, a child swallowed their tongue. Yeah. Putting things in the mouth of somebody having a seizure is never a good idea. Let me tell you that. Um, let's see. The child did it on purpose. I've never seen anybody that can have a seizure on purpose. So that put a wallet in their mouth. I guess that's kind of like a belt. Anything leather they could bite down on. Lots of people have heard that they could swallow their tongue. Several people have heard that kids are faking it. That's really sad. Why would anybody want to fake a seizure? Um, so a lot of you have heard the same things. I grew up in an environment where there are a lot of wives' tales. It can be caused by overheating. You can have seizures from dehydration, like significant dehydration and overheating. But I grew up in a really conservative faith community, and there were people there that thought like somebody who had a seizure was like possessed by the devil. Um, yes, somebody else just wrote that here. My grandma said that they were possessed, which is a wild thing to say. But those are wives' tales and like myths and rumors that go back hundreds or even thousands of years when people first started having seizures, and the world just did not know what to think about that. So there have been some crazy stories, and I hope that after tonight you have some good content behind you that gives you factual information to stand on. I want to tell you one thing before we really kick things off. I'm not a doctor. Well, my title said doctor. I'm a doctor of education. I know a lot about teaching children to learn. I'm not a medical doctor. And so I'm not giving this training from the perspective of a medical doctor. I'm giving this training from the perspective of somebody who was a special educator for many years. And I am also an adult who has epilepsy. I was diagnosed with epilepsy 31 years ago, and I've spent my entire adult life trying to regulate my condition, to live with a chronic health condition, to make sure that I had the medication I needed and I could overcome obstacles. When I start a new job, I have to tell them um, how to accommodate me based on my disability. And so a lot of the information that I'm going to give you is very factual information. But if you want really detail specific, you're always going to be best to talk to a doctor, and most specifically a neurologist. But the information that you'll get today will really help you as far as supporting kids in the classroom and understanding why individuals have seizures and why they're diagnosed with epilepsy. So, what is a seizure? Abnormal electrical activity. So we know that we've got two parts of the brain and that they're communicating back and forth, but messages communicate with electrical impulses in the brain. And so a normal developing person who does not have seizures has those same electrical impulses moving back and forth. But when a seizure is in place, the electricity in the brain just goes a little bit wild. And maybe it is underperforming. Maybe it's overperforming quite a bit, but there is an issue with the electrical impulses communicating between both halves of the brain, within one section of the brain, or even the whole brain. It is sudden and it is uncontrolled. Somebody cannot say, I'm going to stop myself from having this seizure by focusing, by grounding myself. And there's not a lot of warning involved. When someone has a seizure, the brain kind of freezes up. It's like when your computer freezes up and you have to reboot it to get it going again. That's the same thing that happens. The brain is disrupted and normal activities can't happen. Seizures look different ways, so not everyone is going to have the same symptoms, but some seizures include full body muscle spasms or convulsions. A person may be conscious or unconscious. It depends on what type of seizure they're having. But a seizure is not a diagnosis. A seizure is something that you might have as a symptom. Like if you went to the doctor and said, I'm sick, what are your symptoms? Oh, I've got a runny nose, a sore throat, this, and this. A seizure is just a symptom. It is not a diagnosis. Epilepsy is a diagnosis, but not everyone who has a seizure is diagnosed with epilepsy. So, like I said, there are different types of seizures, and we place the seizures into categories based on a few different factors. How much of the brain is involved? Is it just one part of the brain that got overexcited, or is it the whole brain? Whether or not the person loses consciousness. There are some types of seizures where a person can say moderately alert during the seizure, and there are other seizures where the person is completely unconscious. And then whether or not the seizures are associated with other symptoms. What else is going on at the same time? Now, most of you will, if you think about what happens during a seizure, you associate probably with what you've seen in movies. If you've never seen a person have a real seizure in front of you, a lot of people think about, okay, in doctor TV shows, I see somebody who's shaking, like their full body is shaking and having a spasm and they're unconscious and um, it's full body activity. That's what we call a grand mal seizure or a tonic-clonic seizure. And it's what we most frequently recognize as a seizure, but it's only one type of several different kinds of seizures that somebody can have. And so sometimes a seizure is much less um, attention getting. And that can be even harder sometimes when someone's having a seizure, but not everybody knows. So as we're going, you can put questions in the chat and we'll get to them as we have an opportunity. So if you want to like not forget it right now, you can utilize the chat for those questions. The first type of seizure that we're really going to talk about is what we call a focal seizure. And this is a seizure that happens in one part of the brain. So it might just be in one hemisphere of the brain or one lobe of the brain, or it could be like even in just a tiny area of part of the brain. And so it's not going to look the same as some of those larger, more movement oriented seizures. A lot of times with a focal seizure, when it's just part of the brain, that person may remain conscious and aware of the environment the whole time. It may be controlling motor movements, and somebody may have a leg that is significantly twitching or an arm that won't stop moving because of the seizure. But since the whole brain isn't involved, they can still, like the center of speech and executive function and stuff that's up at the front of the brain, it might not be affected. So the person might not lose consciousness and may be able to talk to you the whole time that it happens. Or maybe they just appear to be very confused. Sometimes when somebody is having a seizure, but they're still conscious, they may have a lot of the same characteristics as somebody who's intoxicated and they're kind of dazed. But when these focal seizures occur, they can make somebody really emotional. And that might be that they're sad and crying emotional, but a lot of times they can be very agitated, get really angry, and have very intense responses. And you're like, whoa, why did that person just throw a chair across the room when nothing happened? But the intense emotions can really be affecting the brain. It can also cause them to have a very altered awareness. So much like if somebody were to get a concussion at this a focal seizure, the person might not remember where they are or who they're talking to and may begin asking a lot of questions. Another thing that can happen during a focal seizure is that the individual may keep talking, but the words do not make sense. They don't make sentences. They may be randomly talking to you and they may think that they're having a conversation with you, like, I'm scared, what's wrong? But it may come out that that person is saying duck, couch, car, all kinds of different words because the brain isn't processing how they interpret language correctly. And so it can be kind of scary when you're talking to somebody who's making no sense and they seem really confused. What we often see the most and what we're the most accustomed to is generalized seizures. And that's when the whole brain is affected by that electrical activity and it's widespread and all systems of the body are affected at once. And so the most common that we know about is tonic-clonic. Oh, that says clone, but it's tonic-clonic seizures, which means my whole body gets stiff and then it relaxes and then gets stiff and relaxes. And so it causes these muscle spasms and big convulsions that go along with the seizure. Another type that is really common and really kind of scary in a lot of ways are absence seizures, or we used to call them petit mal seizures. And they're just somebody completely blanks out. You may be talking to them and they may stare off into space and not respond. It's just a blank face because their whole body is frozen. Now, these don't seem like that big of a deal when you're in a classroom setting, you're seeing a kid. But if you think about an adult who's driving a car and all of a sudden has an absence seizure, they can be really devastating if you're in a dangerous position because you don't know that they're coming on and it's not really obvious that the person is having seizures. A lot of individuals that have absence seizures can go quite a while before they get a diagnosis. And so that danger factor can be a big deal if nobody knows what's happening. A third kind of generalized seizures is called atonic seizures, and we often call these drop attacks. All of a sudden, there's complete muscle loss in part of the body, and it may only be on one side of the body, but all of a sudden the person falls to the ground because they cannot control their muscle activity. They may be able to be conscious very quickly afterwards, but depending on where the drop attack occurs, they could be walking down a flight of stairs and just collapse and fall down, or they could, again, be in a vehicle, things of that nature. And the body just loses that muscle tone and cannot support itself. And then the final type on here is called myoclonic seizures, and these are brief, jerky motions. This in myoclonic seizures, the individual may be alert, but again, they could have parts of the body that have muscles jerking, and we see this a lot of times with arms or legs, and it's just out of nowhere. The person's still, they're relaxed, they're doing their normal job, and an arm or leg may jerk really violently once or twice, and then it calms down. The part of the brain that would control that motor movement, just when the brain had the seizure, that individual part of the brain got really overstimulated, and it caused those involuntary movements. So there's a lot of different things that we could see happen when it comes to what a seizure actually looks like. So like I said, tonic-clonic is the most common, but I want to talk a little bit about what it looks like. The loss of consciousness and the muscle contractions are what we usually think about, but there's a lot of things that happen also. One of the things that you often see with a tonic-clonic seizure is that the person having the seizure may have an aura beforehand. Now, an aura is a really weird thing to explain, but basically it's like a feeling or like a deja vu experience or something where the person gets just this little clue that something weird is getting ready to happen. But it's not enough that they could maybe tell somebody else, I'm getting ready to have a seizure. It could be they start to smell something because the part of the brain that controls smell or taste or the different sensory information kind of gets a charge, and so there's a smell associated with it or something that person is kind of like, oh, and they fall into this familiar pattern before they begin the seizure. Unfortunately, grand mal seizures can also mean that the individual may lose control of their bladder or their bowel movements. And so when somebody can also already be very self-conscious about having a seizure, falling down in front of people, those kinds of things, then they also may have to worry about the fact that they may have wet their pants in front of other people, or they may have had a bowel movement in front of other people. And so that's one of the things for kids that is often the hardest, or for adults too, is being in that vulnerable position and then having something else really embarrassing happen. The person will be unresponsive for a while after the seizure. We talked about the computer reboot just a few minutes ago, like when the computer freezes up and we have to hit restart, it takes a few minutes to get things going again. And I've seen individuals that have had a seizure and somebody comes to their aid and they're like, talk to me, and shaking them or trying to get them to respond really quick. And the brain just needs some more time to heal before they can talk. So it could be a few minutes or it could be 30 minutes, depending on the severity of the seizure. But we do need to expect that the individual will need some time before they're able to communicate and be fully conscious again. But even when they do wake up, there's a lot of confusion. There's kind of a haze over them for maybe several hours or maybe a couple of days even. My nephew was just recently, in the past couple of months, diagnosed with adolescent onset epilepsy. And he had a seizure at school, and his mom came to get him, and they were going to go get his backpack and take him home afterwards, but he couldn't remember where his classes were at school. He couldn't remember where his locker was. And he was really embarrassed and upset with himself that he didn't know like where he was in the building, even though the seizure occurred like 30 to 40 minutes before. It just took him quite a while for his brain to kind of heal after that and lose that confusion. The other thing that can be very overwhelming after a seizure is fatigue. When you think about a tonic-clonic seizure, basically every muscle in a person's body is working as hard as it can for 30 seconds to 5 minutes, however long it may last. But when you think about that kind of intensity and muscle strength, then afterwards, every muscle is sore and tired and exhausted, and the body just needs a significant break. And really, after a seizure, the biggest thing that most people need to recover is sleep. And it could be several hours of sleep, or it could be a couple of days of rest. It also can be followed by a pretty intense headache or even a migraine where nausea may be a symptom also. So those are things to keep in mind if you have a coworker or a student that experiences these kind of symptoms, then those are things that could continue for several days. Now, absence seizures, the scary, dangerous ones that we don't always notice, this is a completely different ballgame. You have to do some detective work a lot of times to figure out when a child is having an absence seizure. And I can tell you that when I was still in the classroom every day, there were 4 kids over the course of many years that I found in my classrooms that were having absence seizures. Now, I'm not an MD, so I never diagnose. But knowing a lot about what seizures look like, I could tell. And what I did tell the parents was, I've noticed that this is happening. I've noticed that this and this and this are happening. And I think that it would be good to talk to your pediatrician because I've noticed on this day at this time, this happened. But some of those things that I noticed include that blank stare, staring off into space. You don't know why. Now, all of us have moments where we are staring off into space for no reason. But when a child is having an absence seizure and they're staring off into space, you can't get their attention back by just waving your hand in front of their face, saying their name. They're in a complete kind of trance for several minutes. Lip smacking is another one, and that's going to look kind of like just over and over again. And it's like the brain has a glitch and it just continues to do that again and again and again. Or it may look like chewing too. I've seen kids that are like chewing on the inside of their mouth, chewing on their tongue, but they're just kind of stuck in that pattern. Fluttering eyelids, so it may just look like the person is continuously blinking over and over and over and over again, but it's really like a computer system glitch that they're stuck, and those eyelids are not under control based on the location of the seizure. There could be hand movements. Again, this one, there could be loss of bladder. Typically, these types of seizures only last for just a few seconds, so we don't see the loss of bowel movement the same way that we do in grand mal seizures. But again, once you get their attention again, they typically have no memory of what just happened, other than the fact that they may be like, where am I? What was going on? I don't remember. But there's usually a gap of time that they just have no memory of. When you're in an infant toddler classroom, it's harder to find absence seizures because a lot of kids have on diapers, but in a preschool classroom or a school-aged classroom, children who have an incontinent episode and lose bladder control out of nowhere when they've been toilet trained for a long time, it's usually a pretty good sign that something strange is going on and something that parents would want to know about. And then those repetitive behaviors that they just get stuck on, like the lip smacking and chewing and eyelid fluttering, can all be signs that something is happening and they just can't respond to you. I saw in the chat that there was a question about our tonic-clonic seizures. Somebody asked about breathing control during that. If a significant seizure happens long enough, it can disrupt the breathing where that it can be an issue and have a fatal impact. Seizures can lead to death if they're significant enough. Now, most people have seizures that are less than 30 seconds, even if they're grand mal. But when they hit a certain length of time, that's really scary, then if the breathing is affected, it can cause like a suffocation effect. One of the things that you may have heard about are the acronym is SUDEP. SUDEP. It's sudden unexpected death through epilepsy. And it's when a seizure is so significant and the brain is so impacted, the breathing and other systems shut down, that the person dies from the seizure. It is unusual but it's not as unusual as you would believe. Um, so it is something to keep in mind, unfortunately. Now, febrile seizures are probably something that you all have seen before working with young children. These are typically a type of seizure that kids grow out of, maybe even before the age of 2, but they can be really scary to watch an infant or a toddler have a seizure. But what typically happens is the baby does start to convulse when their fever goes up very quickly. And it can either be that they get a high fever, all of a sudden the baby has a temperature of like 104 or 105, and their body just feels like it's on fire. You're trying to cool them off. Or it could be that the temperature just shoots up so quickly that it causes the seizure. So it may go from 98 straight to 103 and just a 5-degree swing in a few minutes, and the body gets overwhelmed and has the seizure. This can actually come, like it can be a symptom of the flu or an ear infection. It's just because the baby's immune system really hasn't learned how to control those types of things yet. Parents will often tell you about this if they know that their kiddos have febrile seizures. Um, and they are very worried about if the baby gets sick, you have to immediately tell me, you have to do this. We've had, when I was a director, we had children that were prone to febrile seizures. And when they got sick, their temperature shot up, we would take off their clothes to cool them off, put cold wash rags on them until their parents could get there to take them to the doctor. A febrile seizure is really just about getting the body temperature down as low as possible. So I want to tell you some facts about seizures, and these are some of those things that maybe you've heard of before, but every person who has seizures, their seizures are going to look different because there's a combination of all these symptoms. And so everybody has things that are a little bit different. For me, as a person with epilepsy, I have both tonic-clonic seizures and I have absence seizures. Usually when I have absence seizures, I've had issues with saying the wrong words and being frustrated that I can't say them correctly. I've done a lot of the lip smacking and the eye fluttering. With grand mal seizures, I have an aura beforehand, but not enough that I can really warn anybody else. I just realize after I wake up that I had that sensation. And I have like probably a 30-minute window that I can't remember from like pre-seizure, the actual seizure, and the time period afterwards. I'm really combative afterwards. I'm angry because I don't want anybody's help. And when they try and help me, I get really aggravated with them. So, it's going to look different across the board for everybody. So don't ever anticipate, well, I thought that was a seizure, but it looked different than this child that I had in class before, what they did. It doesn't matter. They're all going to look a little bit different, and what causes them is all going to be a little bit different. Most seizures happen without warning, last for a short amount of time, and resolve themselves. But we do have kiddos that are not able to be treated with medication and ways to reduce their seizures. And so we're going to talk about that in a little bit, but it gets complicated when you know that the seizure won't end on its own and you have to use emergency medication. Like I said, with me, a lot of people have more than one kind of seizure. So you may anticipate somebody having a grand mal seizure, but then they also start to have another kind. And it's just that the brain is prone to that electrical overactivity. And so it's prone to multiple kinds of it. So this one is one thing I want to make sure everybody understands. Someone is not diagnosed with epilepsy until they've had at least 2 seizures within a short amount of time, like 2 to 3 months. If a child that you know or an adult has a seizure, nobody is going to diagnose them. If it's their first seizure, they definitely need to go to the emergency room, but it could be from an illness, it could be a random symptom. 1 in 10 people will have a seizure at some point in time in their life, and without being diagnosed with epilepsy. It could be from a head trauma, it could be from a concussion, you get bucked off a horse, all kinds of things that could cause it. But just having a seizure itself does not mean that they have a diagnosis of epilepsy where they'll have repeated seizures in the future. And when it comes to seizures, this is the 3rd most common school emergency. So it is something that a lot of schools encounter, whether it's a teacher at the school or whether it's a child. It is pretty common. Many of you may know what a 504 plan is. It's not quite a special education plan, but it is a plan where kids need accommodations to be in the public school system from 3 years old all the way up until they're in college. There are some conditions that are more prone to have a 504 plan, and a lot of them are medical plans. I know in Fayette County, where I live, the most common 504 plans include type 1 diabetes, ADHD, epilepsy and seizures, and asthma are the most common four. And so it doesn't mean that that individual needs a special ed teacher, because they might have no problem doing their schoolwork, but they are going to need accommodations because of their health condition and what they need to reduce triggers, or for somebody to be able to treat them afterwards. So seizures are more common in our school settings. And for those of us who work in the field of early childhood, most of us don't have a nurse on site. And so we have to know how to deal with some of these situations, even if there's not a medical professional on hand. So again, epilepsy is a chronic illness. It is designated as one of the disabilities that is recognized by federal government for, do you have a disability? And they have a very specific list. It's something that typically doesn't ever go away, although it can be managed and treated. And it really is defined by reoccurring unprovoked seizures. So if somebody were to have a traumatic brain injury, be in a car wreck, that's a provoked seizure. There was a head injury involved and it caused a seizure. But somebody with epilepsy is going to have seizures without um, without a head injury, without something that just sparks it. And it can affect people of any age. The most common time to be diagnosed with epilepsy is in childhood or over the age of 65. But we also have a lot of kids who are diagnosed with adolescent onset epilepsy. Once they hit puberty and hormones start going crazy, then that can also be a time where they start to have their first seizures. There are medications and there are alternatives to medications that can help treat the symptoms. So it is something to keep in mind, that most people that have it can have a very productive life. And it is not a death sentence or a terrible thing that will alter everything, but it is something. When you have it, I think about it on a daily basis, whether or not I want to, because there are certain things that I have to make sure that I'm doing or not doing in order to take the best possible care of myself. So, what triggers it? Now, some of these are just things that a child, like basic needs, they need to happen in their life, but other things could be happening in your classroom that could trigger. So, we want to talk about just a variety of different things that can set off a seizure. The most common reasons that somebody were to have seizures: a lack of sleep. Sleep is hugely essential, just like one of the most important things, that somebody get enough sleep. And we're living in an age where a lot of kids don't get good sleep because they're up at night watching TV in their bedroom or on a phone, that, playing video games or all kinds of things. And so when sleep patterns are disrupted, it is much easier for someone with epilepsy to have a seizure. Missed medication is one of the biggest reasons. And a lot of people with epilepsy have to take medication 2 to 3 times a day, and they have to get into a pattern where they don't miss it. And that can be really tough. If a child were to need to take medication during the school day at your facility, then it is just essential that that medication is never missed and that it is given on time, because some seizure medicines really have a window of time. Like if it's more than 6 hours since your last dose, then the effectiveness has worn off and you're much more prone to have a seizure after that. And then high stress levels also are a huge factor for a lot of people. And we think of young children not being that stressed, but the home environment they live in, the classroom setting that they're in, can often reflect stress levels. If there's a lot of changes going on at home, moving to a new house, having a new sibling be born into the family, kids who live in situations where there might be domestic violence or abuse at home, just increased stress levels can really bring out a tendency towards seizures. The other things I have on here are not as predominant, but they all could possibly affect somebody having seizures. So one is illness and dehydration. A lot of people are more prone to have a seizure after they've had an illness like the flu and the body is really run down and they're dehydrated. A lot of people assume that flashing lights affect everybody with epilepsy and strobe lights, things of that nature. But really only 30% of individuals with epilepsy are photosensitive. One of the things that I want to point out though is it's not just strobe lights that can affect somebody who's photosensitive. You know, one of the things that bothers me the most is when I'm driving in a car and the sunshine is like coming through the tree leaves and it kind of flashes as we drive by. Flashing patterns of light don't have to come from a strobe. It can be from a lot of different things. So, you know, there could be storms, there could be all kinds of things that might, you know, flashing lightning, repetitive fireworks can be an issue in the summer. Different things can cause that flashing light pattern. So that's something to keep in mind. And one of the big ones in school settings is fire alarms. We have strobes on fire alarms so that individuals who are deaf or hearing impaired know that they need to get out of the building. But it can be a big deal to an individual with epilepsy when the strobe light is stuck in that position until the fire alarm gets turned off. For me, one of the accommodations that I've had to have as an adult in different workplaces is that if we have a planned fire drill, I need to leave the building before the fire alarm goes off and the strobe light starts. But when people pull fire alarms or they go off because of, you know, atmosphere conditions and things like that, you can't always control that. If you're in an elementary school or a setting like the YMCA, you could have a child who pulls a fire alarm because they think it's a really cool joke and you can't control that. And you just need to be aware that if you have a child in the classroom that has seizures and is sensitive to light, that we get them away from the fire alarm as quickly as possible. Hormone fluctuations are a huge reason that individuals can have seizures. And if you work in school age programs and you have girls that are reaching puberty and may start to have a monthly cycle, then they could be prone to having a seizure once a month with that fluctuation in hormones. Same for adults. Also, it can affect pregnant women quite a bit. So if someone with epilepsy is pregnant and having a baby, the hormone changes during pregnancy and the hormone changes after pregnancy can have a huge impact on their threshold for having a seizure. Playing video games and prolonged uses of screens can also have a really big impact. And this kind of goes back to the photosensitive um, region, but it's the pixelation of the screens and how the movement of the light for extended screen time exposure can affect kids. One of the tests that doctors often do to study the brain in somebody who has seizures is they induce a seizure and they have little electrodes like glued all over the person's brain to see where the brain activity is. And if they have a patient in the hospital who is not having a seizure, one thing they often do to help induce a seizure is to get them to play video games for an extended period of time. Another thing they often do to try and induce a seizure is excessive caffeine consumption. High levels of caffeine can cause intense seizures. And now we have all these drinks like Alani that we have third graders drinking, you know, different high energy drinks. And we've had warnings at places like Panera that say these high energy drinks can cause heart attacks. But for somebody who's prone to seizures, high intense levels of caffeine can also cause a seizure and not just a heart arrhythmia. So those are all things to keep in mind. There are individualized triggers that some people have. There's a form of epilepsy called mucinogenic epilepsy. It's very rare, but the person hears certain sounds or certain types of music, and the music will cause them to have a seizure. So really, you have to get to know the children in your care and what their triggers are. Families usually become really aware of this quickly, but if they're going through the diagnostic process and learning that they have this condition while they're in your classroom, then it could be a learning process between you and the family together to find out those triggers. Okay. Um, so again, possible seizure triggers, just in general, temperature with febrile seizures, extreme high or low blood sugar. So if you have a child with diabetes in the classroom, like a type 1 diabetes, that is just in the process of learning how to control their blood sugar, or even we've had some really little kids in Kentucky in the past few years that have been diagnosed with type 2 diabetes, but high fluctuations in their blood sugar can also um, cause seizures. Traumatic head injuries, withdrawal from drugs and alcohol. We see this a lot with infants and toddlers. If the mother is nursing the baby and they're using some type of substance, whether it's alcohol, drugs, pain pills, that kind of thing, the baby is more apt to have a seizure due to withdrawal. It doesn't mean that the baby has epilepsy, but these are reasons you could see seizures in general in the classroom. Infections, if a child were to get meningitis, encephalitis, they can often have a seizure that is not related to epilepsy, but it could be something you could see in a classroom setting. So these are just other things to keep in mind that aren't related to epilepsy, but are reasons for seizures. So what do families do for treatment? The most common form of treatment, even for a young child, is to do medication. Most people do pills. There are some medications for really young children that they make a liquid form if the child isn't able to swallow pills yet, but still some type of oral medication. I will tell you that there are tons of seizure medications on the market now. When I was growing up, there were like 3 or 4 to choose from. Now there are just tons and tons of them, and some are used for multiple purposes. They could be the same pill may be used for depression and anxiety in one person, but it can stop seizures in another person. So like medication now has all these different uses. But even with all the medications that are on the market, there are some kids that just do not respond to typical medication, or that it doesn't process fast enough. There are emergency medications available for children whose seizures won't stop on their own. And so I've had a student in my care when I was a director that once he had a seizure, we had to use a suppository to get the seizure to stop, and then call for the parents to come and take him to the doctor immediately afterwards. But the staff was obviously a little freaked out about having to give a suppository to a child, but it was the same as an EpiPen or emergency inhaler as far as saving the life of a child. So that is something that families may come in and ask you about. Um, when babies are really little, they use suppositories for medication if they can't suck on the medication dispenser and things. So it's something you may have had experience with when you're caring for children. The biggest thing when you have these emergency medications is to make sure that you have a plan with the family and they explain and put in writing how they want you to handle it and what you're responsible for, and that you see their wishes are written down and signed saying that this is what they want you to do. That way, if there would be any complications with the suppository or anything like that, you're like, well, you told us to do this, and this is how we followed the plan. They've come out recently with a really cool little inhaler nasal spray that also stops seizures if a child has a prolonged seizure. So hopefully more people are moving towards that from the suppository, but it depends on what type of medication the child responds to well. Children that have really persistent seizures and they don't stop very well may have a brain surgery to install a device in the brain that will control the electrical impulses. It's called a VNS. It basically tries to get the rhythm of the electrical impulses back on sync and prevent the seizures from happening. And so you may have a parent come to you and say, my child has epilepsy, but they have a VNS. And, if you notice anything, let me know, but it should resolve a seizure really quickly after it begins. Some VNS devices will completely stop seizures. They're used in both children and adults now, and they've done miraculous things for people that cannot be treated with medication. But because you're dealing with the brain, there can always be some weird side effects because we never know exactly how the brain is going to respond to things. It's always kind of will this work? Will this not? The other thing that you may not know is that the ketogenic diet was originally created to treat epilepsy, which is a high protein, high fat diet, low carb. A lot of people really got on board with ketogenic diet like 10 to 15 years ago, big dieting weight loss trend. It actually didn't become popular with, the weight loss crowd until after people had used it with epilepsy to help reduce seizures for those who didn't want to use medication or couldn't use medication. It wasn't working. Um, but you may see children who have a special diet that need to be in your program, that need to have high protein, high fat, low carb type of diet in order to help reduce their seizures. So fun fact there. I will tell you, oh gosh, it was like 5 or 6 years ago when I was still at the Division of Child Care. We had one of the first seizure dogs ask for permission to be in a licensed child care center in Kentucky. Now, if a child gets a seizure dog, they are a type of therapy animal. They cannot stop a seizure, but what they do is they stay with that child all the time. And for a child who's having 15, 16 seizures a day, uncontrolled, the dog notices the signs that lead up to the child having the seizure, and the dog will start to bark right before the child has the seizure so that you can get them laying down in a recovery position. They're less likely to get hurt if they're running or climbing on something, things like that. And then the dog will stay with the child after the seizure while it recovers and kind of help calm them and help them re-enter the classroom environment. So many questions about a dog in a classroom. I had people calling when we had the initial request. It was a center in Lexington, and the center was calling on, but a dog is not on the approved list of pets, and we're not supposed to have him. And what if somebody's allergic? And all kinds of questions that came up. They're all good questions. There are other kids in the classroom that might be allergic to dogs, that could be afraid of dogs. Maybe they've been bitten before. I'll tell you this, if a animal has the papers to prove that they have been trained as a seizure dog, they mean business. They are a well-trained medical professional. Typically, you do not have to take the dog out to the bathroom all day long. When they come to school, they are ready to work, and they do not take a potty break until they leave with the family at the end of the day. So it doesn't put any additional burden on the teacher, like having to take the dog out to the restroom or anything like that. Um, you cannot tell a family no if they say that they have a seizure dog that they want the child to come with. It is an ADA violation. If the child was admitted into the program and you're willing to care for them, and then all of a sudden they say, and they have a seizure dog that needs to come with them, then it goes against the American with Disabilities Act to say no, they can't come. Now, if you're a large enough program where you might have 2 3-year-old rooms and the dog is going to be in one, then you may need to ask families, is there anybody that's allergic to dogs? Is there anybody who's scared of dogs? Maybe they want to switch to the other classroom if you have that ability. There also is a fair amount of training you have to do with the kids in the classroom ahead of time to talk about when the dog is working, we don't play with the dog. And most of the time, if a child has a seizure dog, then the company that they got the seizure dog from has a training program for the classroom, for the kids in the classroom and the teacher, where that somebody might come and talk to the kids about, this is why the dog is here. He's helping our friend who's been having seizures. He's going to let us know if he's in danger of getting sick, and then we can help him. And your job is to not keep him from doing his job, those kinds of things. So that is kind of I guess it would fall under treatment, even though it doesn't stop the seizures, it does help with safety. So keep those things in mind. Now, let's talk about what we do when a child actually has a seizure. So many of you put in the chat things like put a wallet in their mouth, put a spoon in their mouth. Are they going to swallow their tongue? All those kinds of things. That is not what we do when somebody has a seizure. When we are thinking about first aid for individuals with seizure, whether they're a child or adult, there's a few key things that are absolutely essential. Somebody needs to stay with the person to make sure that they're safe. When you have somebody who collapses on the floor and starts having a grand mal seizure, the way that they're moving back and forth, if there are things close to them, they could easily get hurt, they could vomit, and if they're not turned on their side after the seizure, they could aspirate on the vomit, things like that. So we do want somebody to be there to be with the person and keep them safe. After the seizure, we want to turn them onto their side. Does anybody know which side it is for the recovery position when you think about your CPR and first aid training? Anyone? Anyone? Okay, I'm looking at the chat. Left side, yes, they want to turn on their left side so that they're less likely to get sick afterwards. And then we also want to time the seizure. That is the one thing that EMS and doctors are going to ask you immediately if they show up on scene. How long has the seizure lasted? Most of the time, it's going to be less than a minute. But it could be much longer. And if so, then they need to know the significance of the seizure. And that's going to be critical as soon as the child hits the floor. Somebody needs to time it. Those are the biggest things that you can do to help is stay with them, keep them safe. That could mean pushing furniture back. It could be moving, having somebody move kids away, things like that. But you want to make sure that they don't hurt themselves on anything that's surrounding in the classroom. And so just shove the furniture out of the way, those types of things. If they're sitting in a chair, you could help ease them down to the floor so that they don't fall. But whatever it is, get them to a safe place after the seizure, roll them on their side and time the seizure. Now, out of these four things, at no point did I ever say restrain someone or stick something in their mouth or anything like that. So let's go over the things that you don't want to do if somebody is having a seizure, because this is where people seem to get confused. Do not ever try and restrain somebody, like bear hug them when they're having a seizure. When somebody's having a tonic-clonic seizure, every muscle is working. They can beat the snot out of you. If you are trying to restrain them, all it will do is beat you up and beat them up, and then both of you are going to be all bruised up afterwards, but it will not do anything to stop the seizure. So that is not something we want to do. We do not want to put anything in that person's mouth. First of all, most people, when they have a seizure, they instantly bite down and their teeth are clenched. Like their teeth are clenched, they're as tight as possible. You try and shove something into their mouth, you're probably going to break their teeth. One of the biggest things that happens for a lot of people when they do have a grand mal seizure is they chew up their tongue really badly because they bite down on it on the sides. When I wake up from a grand mal seizure, my tongue is like dark purple, bruised, and may even be a little bloody on the sides from where I've bitten it. But if you try and shove something in there, it can make that pain even worse. And then at the bottom of this list, do not try and hold the person's tongue. For some odd reason, somewhere along the way, somebody decided it would be possible to swallow your tongue during a seizure. Now, I don't know about you, but underneath my tongue, I have this little piece of skin that holds my tongue in my mouth. And it makes it so that my tongue is not going anywhere. And I do not know of anybody who has had a seizure and swallowed their tongue. Now, there are people who have swallowed vomit, and that we want to avoid. That's why we turn them on the left side. But there's no reason that you need to try and go in and pull somebody's tongue out and hold it. It'll make the biting of their tongue much worse, and you could get your hand bit off in the process, in all sincerity. Because that person is involuntarily having muscle movements, and clenching their teeth is one of them. And so keep your hand away from their mouth in general and make sure that you don't get hurt and they don't get hurt. All right, I want to talk about calling 911. If it is the first time you've ever seen somebody have a seizure, you call 911. Always. With young children, it's always safe to call 911. If somebody is pregnant or they've had a head injury or they have diabetic related issues, it is always safe to call 911 and make sure that they are safe. But I can also tell you that once somebody has a diagnosis of epilepsy, they may not want to have 911 called and pay for an ambulance ride for each seizure just so that they can get to the ER and the doctor say, well, you had a seizure. I do not want to pay for those bills just so that somebody can say, well, you had a seizure. Thanks. I knew that. I have epilepsy. So you may have families that approach you and say, please do not call 911 unless the seizure is over 5 minutes, or unless you can't get the seizure to stop, or unless this happens. I would say if a seizure lasts more than 5 minutes, always call 911 regardless, because that's a long time. Or if the seizure is blood sugar related or pregnancy related, always call 911. But please be aware that you could have families that put in writing to you, do not call 911 for every seizure, because there are kids who have multiple seizures every day. And they don't want to be running back and forth to the hospital all the time when the doctor's not going to be able to treat that seizure after the fact anyway. And it can be $500 per ambulance ride plus the cost of the ER. So it is very probable that someone with an epilepsy diagnosis may ask you not to call 911 for each seizure. And this is where I think it's really important that we have medical plans on file for kids who have chronic illnesses and disabilities. And all it really has to say is the child's name, their diagnosis, any medication that they're on, and then what steps the family wants followed in the event of an emergency, where the family can sign off. Because if they don't want you to call 911 and you don't call 911, as a child care program, whether you're a family child care home or a center, it's always nice to have our like behind covered and have in writing that they told you not to call 911 in this situation. But for somebody with an epilepsy diagnosis who does have seizures on a regular basis, it could be really costly and ineffectual for the family if they went to the ER for every seizure. Please keep that in mind. So when we're thinking about in the classroom, what strategies we need to be aware of for these kiddos, here's some things that I want to talk about. Medication is the most common treatment, but medication can have some serious side effects. And you are there with that kiddo 8 hours a day, maybe. So definitely more awake hours than mom or dad or granny have with the child. And if they have side effects that start to show up, you're probably the person that's going to see them first. One of the most common seizure medications on the market right now is called Keppra. That's the name brand. The generic name for it is levetiracetam, which everybody I'm sure can say. It's like 25 syllables of consonants. But Keppra has done amazing things for those of us with epilepsy. It's one of the 2 medications that I take every day. It's one of the medications that has the fewest side effects. It doesn't damage the liver like other medication used to, all kinds of things. But in some people, it has a side effect that we call Keppra rage. And let me tell you, the individuals who have the side effect of Keppra rage are ticked off. They are angry and irritated a lot. And parents might not know that if their kids are exhausted by the end of the day and they're just doing dinner and bath time and going to sleep. But if you see a child who consistently is having these really rage intensive episodes, then that can be a significant side effect of the medication. And it also means that that medication is probably not the best one for them. Medications can cause other weird things. I have had so many side effects from medications over the years. I've probably taken 8 or 9 different seizure medications over the years until I found the one that works best for me. I had some that like I had a face twitch and my cheek just moved all day long for no reason, like it was having its own seizure. I've had some that made my hands twitch and go numb, and then I had a hard time writing because I couldn't really hold my pen or pencil the way that I needed to. There's just lots of different side effects that can come up. And so when I had kids in the classroom, whether it was epilepsy or other disabilities where they took medication, I always kept a log, just a really cheap 99-cent notebook. You can go to the Dollar Tree or what's now the $1.25 tree or whatever. Just get a notebook that you can write down anytime you see a symptom that might be related to the medication, and make sure you share that with the parents, because the doctor needs to know that in order to know if the dose is right, if the medication's right. And sometimes just after a growth spurt, or if you work with school-age kids and they start to like pre-puberty symptoms and stuff, they may have to change medication because of what's going on in the child's body. Other things with epilepsy, a lot of kids experience anxiety and depression once they have a diagnosis. Once you're told you have a disability that's going to affect you the rest of your life, even if you're young, sometimes for a 3 or 4-year-old, they become anxious or depressed just because they can tell that their parents are upset about it. They might not understand the significance of their diagnosis, but if they're watching their mom and dad and granny get all upset about what the doctor has said, then it can cause them to feel guilty or ashamed, or lots of different emotions that lead to that stress and anxiety. So we want to keep an eye on those kiddos. And again, that's really crucial information to share with families, but it's also something that we want to make sure all of our kiddos in the classrooms know that they're special, that nothing that this isn't their fault, and look for those verbal cues that they may give you. These same kiddos are probably missing school a lot for doctor's appointments. And so they may begin to be isolated from the other kids in the class if they've missed a lot. Their sleep patterns may change if they have to do overnight visits, or they call them sleep deprived EEGs. And EEG is the test where they tape the little nerve connectors to in their hair to their brain and then flash strobe lights at them to see where the seizure activity is happening in the brain. But they can do those for as long as 72 hours and not let a child sleep that whole time. Well, if you have a 4-year-old who hasn't slept for 72 hours, they come home, they try and sleep, they come back to school, you can see some really weird side effects that are going to come along with everything that they've been through in those irregular sleep patterns. So doctor's appointments can have a big impact. Also, there is a lot of family stress involved. First of all, it can be hard for families just to come to grips with the fact that their baby isn't perfect. With any disability, we call this chronic sorrow. Mom and dad, when they are getting ready to have a baby, they have huge dreams for their baby. Every parent or soon to be parent, whether they're a birth parent or an adoptive parent, is dreaming about everything that their child is going to get to do one day and all the opportunities they want to have. They're thinking that they could be the first, president of the United States one day, or, a ballerina at the Met, or a Major League Baseball pitcher, all these amazing things. And then they find out a diagnosis of a disability that's going to limit what their child can do. And in all sincerity, it means that that parent has to grieve for the child that they dreamed about. They're mourning for the child that they didn't get to have. Now, it doesn't mean the child that they have is not, they can love that child immensely, but their brain kind of has to reconcile that their own child isn't going to be able to do exactly what they expected. And so there can be a lot of family stress just from dealing with a diagnosis. But with epilepsy, there's probably also a lot of family stress from all the medical tests and all the medical bills and trying to find specialists. And depending on where you live, families may have to travel 5 or 6 hours to get to a hospital that has a pediatric neurologist or somebody that can help them get medication and get treatment. A lot of families notice something going on and then they have to be on a wait list to see a specialist. They may be a long way away from a hospital that has a specialist. When I grew up in Owensboro, which is one of the bigger towns in Kentucky, but we only had one neurologist, and they didn't treat just kids. It was he treated uh, anybody, but he didn't specialize in adolescents or things like that. And so a lot of the information that we got was correct, but not exactly. And so we ended up having to travel to St. Louis to see a pediatric specialist at Washington University Hospital. Now, there's a lot more specialists now. We've got UK Children's Hospital, U of L's Children's Hospital, different places that people can go and get treatment. And then in Kentucky, we're lucky to have some big children's hospitals around us, like Cleveland Clinic or Cincinnati Children's Hospital, Vanderbilt. But most of us don't live close to those big hospitals. And so if that's where you have to go, then that can mean, leaving home for a week, having inpatient visits, families staying at the Ronald McDonald House, all kinds of stress. And just, I know right now, watching my sister-in-law with my nephew who's just been diagnosed, she is worried about him all the time. He is mad that she's following him around watching him because he is a freshman in high school and wants to be independent. She is worried that he could have a seizure at any minute. So she's chasing him around all the time, driving him nuts. She's calling his teachers all the time, asking if he's okay. And so there's a stress level of, is my baby all right? No matter how old that baby is. And so you could have a lot of helicopter parents coming in your classroom every day, asking what's going on. They see a light bulb flicker that could be going out that looks like it's strobing, and they ask you to immediately change the light bulb. Just any little thing that is worrying them. Be patient with them. They're trying so hard to deal with the stress, but they're worried about their kiddo, and it's hard to step back. I do want to talk about some of the triggers that you could possibly have in your classroom. How many of you have those big long light bulbs that are like almost a yard long, that like you put 3 of them in a light thing above? Those are some of the worst light bulbs in the whole wide world. They have this oscillation where they shine light, and a lot of kids who are susceptible to seizures can see the strobe in that light, even if you can't see it with your naked eye. Sometimes the lighting in the room has to be adjusted. I know in a lot of special ed classrooms, they will keep the overhead lights off and put lamps in the room to have calmer light that don't have those really high oscillating bulbs that kind of have like a hum to them. Um, you also have to think about computer time. Sometimes these kiddos can't have computer time at a young age because it can be overwhelming for them, but we know they all love computer games and computer time, and so they can be upset with that. Um, Sometimes it's sensory over, like just the overwhelming sensory input in the room. They may need to walk away and take a break, have somebody give them a walk down the hallway to get out of the room, because sometimes lots of smells and sounds and lots of excitement in the room can be enough to be overwhelming to a system and kind of cause the brain to go haywire. I would encourage you to think about your playground too. Um, Kiddos who are having seizures can still be on the playground and play. Please don't take that away from them. But we want to make sure that we're up to date on like the padding on our playground. Every year we get new mulch or we get new pea gravel or whatever it is that you put down as your cushion. We need to make sure that there's the appropriate amount of that, that it's cushioned enough. So if a child were to fall off a piece of equipment, that they would still be safe, um, and keep those things in place. There can be, as far as like activities, when you go on a field trip, you really want to think about who is the chaperone for a child who has medical conditions. They are able to participate in everything. As an adult with epilepsy, I drive a car. I have, I went to school for 3 different degrees. I did all kinds of things that it didn't limit my life, but it is important to know that where a child with a chronic health condition is when you go on a field trip in case there's an emergency. What would need to be done if the person that's chaperoning them knows, the type of seizure first aid they would need. Does the child wear a medical alert bracelet where if they got away from somebody, there would be identification of their condition, their name, who to call, those kinds of things. And then I saw some YMCA people on here for school age program. If you do pool trips, this is one that you have to think about as well. You need to know what kind of swimmer the child is, and you need to have somebody within arm's reach of the child in the pool in case a seizure were to ever happen in the water. Um, those are all big things to think about. But again, when I have a child that has a medical condition like epilepsy that needs different accommodations, different treatments, things like that. When those parents enroll, that's when I sit down with them and create a medical action plan. And that needs to be on file for the child. It's not a licensing regulation, but it is a best practice thing that you have the medical action plan on file and it's updated every year, because as a child grows, their condition usually changes, their treatment usually changes. But, have in there questions that you ask the family, like, what about field trips? Are you going to go on the field trips with the child? Or if we take a child on the field trip, what do we need to know? Is the child able to swim? Is that something that we need to be worried about? What are their biggest triggers? Like if the child really, a lack of sleep is the biggest thing and the child isn't feeling well at school, then we should probably let them nap during classroom time, even though we don't typically do that for other kiddos because that's what they physically need to recuperate. Um, do they need more access to drinking water during the day than other kids? Do they have their own water bottle with them so that they can remain hydrated and that doesn't become an issue? So think kind of out of the box. Think of a list of questions that you would want to ask the family, and then also make sure you know if there's medication that needs to be at home. For me, I take my seizure medicine first thing in the morning and when I go to bed at night. So I would never need to have it in the middle of the day. But there are still kids that might have emergency medication on hand. So if a child has emergency suppositories or emergency inhaler to stop a seizure that won't end, that is emergency medication the same way that an EpiPen is and would be stored the same way. And you wouldn't necessarily have to lock it up in order to have access to it very quickly, but you would have to have it in a place that's out of reach of children and be readily accessible if a child's seizure will not resolve on its own. Okay. I keep going back every time I look at this. So Um, these are just reminders, but when we're dealing with kids with disabilities, I talked to you about Kepper Rage. there are some side effects that nobody anticipates. Having any child in your home, being the caregiver of a child with a disability automatically increases your stress. And with increased stress, it's easier for parents not to always make great decisions. And I can say that for myself, when my stress level is high, whether it's from work, whether it's my car is broken, whatever, I'm just not as much fun for my kids to be around. When a family is dealing with a chronic illness and a disability, it can escalate their stress level. And with stress increases come an increase in abuse. So if we know that a child is having really aggressive behaviors because of their seizure medicine, and then we notice some of those warning signs of abuse, those are things to keep an eye out for. It might not necessarily be a parent, it could be a sibling, it could be anybody, but our job is not to investigate. Our job is to report the facts because we are mandatory reporters. On this slide, we have the Child Protection Hotline that you can call. Remember that if you see the signs of what could be abuse, then you are the person responsible for reporting. Your organization may want you to tell the director and you report together, but don't ever assume that the director will do the reporting without you being there. Because if the director forgets and doesn't report and you are the one who saw it, you're still going to be the one responsible for not reporting. And not reporting child abuse in the state of Kentucky has a penalty of either a $250 fine or up to 90 days in jail. I could pay a $250 fine, but there is no way I want to spend 90 days in jail. And there is no way that I don't want to make sure that the kids that I'm caring for stay safe. So we know that all of our kiddos with disabilities are 3 to 4 times more likely to be abused. When I was a young teacher, I used to think that was mainly like our nonverbal kids or our kids in wheelchairs because they couldn't report or they couldn't get away from their abuser. But we've seen a huge increase of abuse cases in children with challenging behaviors because it can be really overwhelming for their caregivers. And our kiddos with epilepsy, although it's not a behavioral condition, medications and things like that can cause really challenging behaviors that can increase the stress level in the home. So please keep that in mind. So before we finish up, there's a couple things we have to do after this, but I'd like to open up for questions in the chat if there's anything that you have a specific question about. Like I said, I can't get really down and dirty in medical details, but I can give you overall guidance on what this looks like with kiddos or even staff members. Genetic. Okay, so somebody asked the cause of epilepsy. Most cases, we don't know. It does genetically run in families. It can be attributed, somebody can develop epilepsy after a traumatic brain injury and they continue to have seizures the rest of their life. But I'm the only person in my family who's ever had seizures in my biological relatives, and we have no idea why it developed. Sometimes it can be from a cyst or a tumor in the brain, but other times it could just be the biological makeup of the individual. So it's really hard to identify the reasons. Most people have what we call idiopathic epilepsy, which means we don't know why they have it. Good question. Any others that you all have you want to throw out there?
There was one question earlier about whether people usually outgrow seizures.
They can. Febrile seizures are kids almost always outgrow those. In some cases, with a lifelong case of epilepsy, you can be on the same medication so long and it does a good job, and then eventually you stop having them. It doesn't mean the condition has gone away, but it appears to be under such good control that it doesn't occur anymore. Right now, next month it'll be 12 months since my last seizure because I've been able to learn how to get the sleep that I need, take my medicine when I need to, and control my stress to some degree, but sometimes that's out of my control. But what we notice is that when you live with this illness over time, you start to learn how to take care of your body enough that it diminishes and isn't so visible. Keto diet is successful for some people, but not all people. It's an option that a lot of people try if they are adverse to medication, but there are a lot of people that use it in sync with medication as a way to kind of help regulate that. Any other questions that I missed? All right. Let's move on to our end kind of housekeeping here. These are some of the resources we use tonight. Again, the Kentuckiana Epilepsy Foundation has a great website. It's the Kentucky branch of the Epilepsy Foundation, which is just epilepsy.com nationwide. And also the American Academy of Pediatrics has some great resources. They also have on their website a section on how to manage chronic health conditions in schools that is really great to look at. It's the last address there at the bottom, patient care and in school health. And they have some samples of like medical management plans that you could use and things like that. So it's really helpful for childcare programs, schools, nonprofits to kind of get an idea on how to support those kiddos in the school. Other things, in order to get credit for tonight, you cannot leave this training without finishing our SurveyMonkey survey so that we know you completed the whole training so that you can get the 1.5 hours of credit. You may scan this QR code or Courtney will drop the link into the chat that you can do. But that is what will get you ECE TRIST credit so that we know you stayed on the whole time. As soon as you finish as soon as you log on to the SurveyMonkey, like if you open the link, you're on there with the SurveyMonkey, you can log off of this training now, just complete your survey. Or you can scan the QR code and it'll bring it up that way. It depends on how comfortable you are with those types of things. I'm going to come back to this screen in just a second, but I'm going to kind of review the others. Thank you everybody who came today. Here, let me show you this. This is my email address at KYA if you need if you have questions, if you would like to request certain topics, we're doing these every other month for free on different aspects of childhood disabilities, how to support those kids in the classroom. We'd love to hear your feedback. So thank you for all that you do with to take care of Kentucky's kiddos, and let us know if there's a topic that you really want to learn more about. There's a place in the evaluation in the survey for you to put that. Also, please know that Face It has a lot of abuse awareness materials that you can access for free. You can scan this QR code. You can order these off of our website. These are things you can give to parents. We have things on there like how to calm a fussy baby, what to do about toddler behaviors that drive you nuts, body safety, teaching body safety to kids at a young age, cyber safety. All these are available for free. We can ship them to your program. They're great for childcare providers, but they're also great for parents to know, particularly things like cyber safety, body safety, that might not be in their skill set, but it can do a lot to reduce a child's chances of being abused in some way, shape, or form. So other than that, you can follow us on social media. We're on all kinds of different platforms, and our website is faceitmovement.org.